Can you see me? Guys, can you hear me and see me? If yes, you just give me a thumbs up. Okay. Okay. Welcome back, guys. This is Dr. Ranjith. I'm good, Jay. Good evening, Shruti. Good evening, Muskan. Next few days here is both on the YouTube channel form. What we'll be doing is we'll be having series of revision series for INI-CET. I'll sort out a timetable so that your basic from general pathology to hematology. So once it is done, we'll have a series of questions here as well. We'll be discussing more in the question format rather than the theory. Focus towards INI-CET, so it'll be helpful for us to, if at all anything comes, we'll be able to take care of it. Lag, there is a lag. Just a second. Hello. Is it fine now? I hope it's fine. There's a little bit. I hope this is clear at least. My side it looks clear. Let's see how it comes on the other side. Hopefully it's clear on the other side as well. If it's not clear still, let me know. Let's work out on it. Fine. Okay. Thank you, Deep. Is it clear? I am able to see myself at least in a better position than before. Okay, so let's get back to the question. Fine. Okay, coming back to the question, it's an 31-year-old man who collapses after running 15 kilometers, and we have all the informations given there. And we have the sodium potassium chloride values. Hematocrit and hemoglobin is primarily elevated. Fine. So hematocrit and hemoglobin is primarily elevated. So once I have a history which is more towards your polycythemic state, right? So of the options, I can rule out erythroleukemia. We guys know that erythroleukemia is nothing but an AML, right? AML M6 is otherwise known as erythroleukemia. So I'm ruling out this for the only primary reason my WBC count is reduced, and these are not exactly, definitely not exactly the clinical symptoms of a leukemia, right? So diabetes insipidus, I might lean towards diabetes insipidus if you're going to consider this person alone. Only the values of the sodium potassium, because one, we are not so clear about what happens in diabetes insipidus, right? That's one problem. And moreover, it's more, it gives an euphoria for us to diagnose a case of diabetes insipidus. But here, I have a history which is not going with diabetes insipidus. So history is totally unlikely for diabetes insipidus, so I'm taking it away as well, right? So I have two more things, hemoconcentration and COPD. COPD again, no, because clinical history is not for COPD, right? So definitely a person with COPD will not have a temperature of 40.1, and after running a 50 kilometer, no perspiration, that's not a feature of COPD. So there is something which is like a heat stroke or something where the patient is having a hemoconcentration, right? The hemoconcentration is the reason here. Hemoconcentration will be the answer here as well. So once we have hemoconcentration, hemoglobin will definitely be elevated and hematocrit also will be definitely elevated. Maybe I can call it kind of a secondary polycythemia. So this question, the premises is to discuss about something about polycythemia. Polycythemia is a very, very important topic. There have been repeated questions which is coming on polycythemia, and most of the time, almost every question of polycythemia, whether it is medicine based or whether it is pathology based, anywhere, it can be cleared by a flowchart given in Harrison. Harrison gives a beautiful flowchart on polycythemia, how to diagnose and how to work out the polycythemia cases. Please follow the same flowchart even in your clinical practice when you see a case of polycythemia, right? The first thing what Harrison says is, when you have an increased hematocrit, we are just going to recreate the flowchart or hemoglobin. What am I going to do? When I have an increased hematocrit or hemoglobin, the first thing I'm going to do is, I'm going to look at the RBC mass, right? You're going to look at the RBC mass, whether RBC mass is also elevated, or measure the RBC mass. Neha Patel, COPD carbon dioxide accumulation might be correct, but I cannot explain lack of sweating in COPD. or the elevated temperature of 40 degree in COPD and the abnormality of CBC findings in COPD. So we are going to take it away. It's fine. Okay. So measure the RBC mass. RBC mass here, I'm sure in your physiology practicals you must have seen that the chromium tag guide, all those are exact tests which give me the RBC mass, which I'm not going to do it in a real life. For us, RBC mass is your RBC value. You do a hemogram, you'll have an RBC value, that gives an RBC mass for sure. Based on the RBC mass, again, if the RBC mass is normal, I'm going to call it an relative polycythemia or relative erythrocytosis. Relative erythrocytosis is where this case will fall under. It's a hemoconcentration, right? I have no problem in my production of the RBC. RBC is fine, but there's more concentration here, like dengue fever, where there's a capillary leak. Everything will come under relative erythrocytosis, right? Your relative erythrocytosis is where your dengue comes, your hemoconcentration comes, and everything comes under this. Okay. It's in relative erythrocytosis where I have features of polycythemia, but the RBC mass is more or less normal. Next is, if the RBC mass is also elevated, please do not go first into the diagnosis of polycythemia rubra vera, the neoplasm. Neoplasm any day, not only in MCQ, even in your real life, should be the last finding you're going to see. Fine. If it's elevated, if my RBC mass is elevated, the amount of RBC is elevated, the most important criteria, this also comes in your criteria of polycythemia rubra vera diagnosis as well, is EPO. Tell me what will happen to the EPO levels in case of an polycythemia rubra vera, which is a neoplasm. The erythropoietin levels will be elevated or will be reduced. It's a neoplasm. Every neoplasm has one rule. It should not follow it should be present even after the growth stimulus is removed, right? So if my EPO levels are elevated, I'm going to have one diagnosis. If my EPO levels are low, I'm going to have another diagnosis, which is going to be, if EPO levels are low, I'm going to think of an polycythemia rubra vera, right? If my EPO levels are elevated, next I'm going to measure oxygen saturation. See, till this, I'm sure all of you must have known, right? Till this, I'm sure all of you must have known. Polycythemia rubra vera, you must have diagnosed. Measuring oxygen saturation, again, has lots of things. I'm going to have, let's say, lung-related disorder. I can have a hemoglobin-related disorder. I can have like a paraneoplastic system, which is calling polycythemia vera, right? Lots of findings are there. If my EPO levels are elevated, measuring oxygen saturation with a simple pulse oximeter, again, I'm going to have two possibilities. Low oxygen saturation, normal oxygen saturation. Okay. If my oxygen saturation is low, which means primarily I have a problem in either of the lung disorders. My lung is not functioning properly, right? Here I'm going to have lung disorders, lung or heart disorders, because both are required for me for saturation, right? Lung or heart disorders, your cyanotic heart disease. Any case of cyanotic heart disease will fall under this. Could be a chronic lung disease. Could be a chronic lung disease, or it could be an high altitude, where again my lung is not having enough oxygen for it to breathe in and breathe out, right? Normal oxygen saturation. My oxygen saturation is normal. You're going to answer this. If you're going to be sitting in a clinic, tomorrow you're going to sit in a clinic, or you're sitting in your OPD as an intern, you're seeing a patient who gave a hemoglobin value of 19 gram percentage, definitely high. What will be your first diagnosis? Perfect. Your first diagnosis, whenever you see, it's going to be the most common one, right? The most common cause of polycythemia is obviously going to be smoking. I want you to remember this. You might go wrong here. In smokers, oxygen saturation will be normal. My body thinks, right? Listen carefully. My body thinks I'm at a hypoxic environment, compensates producing more erythropoietin, compensates for hemoglobin. It's compensated here. Right? It's compensated here. That's why my saturation becomes normal. In a cyanotic heart disease or in a decompensated lung disease, where compensation is not there, I'm going to have low saturation. Otherwise, it's going to have normal saturation as well. So COPD also, if it is compensated, can come to this category of normal saturation also. Just keep that in mind. Fine. So next here, again, I'm going to have one more thing. If smoking history is present or not present. Yes or not present. If yes, I'm going to directly say it's a smoking related polycythemia, no issues for me. If there is no smoking history, oxygen saturation is normal, EPO levels are normal, there's no smoking history. See, this is a new category for us. We are going to learn a little bit about this. If there's no smoking history, no problem in the lung, no problem in everything, Bhumi, yes, in polycythemia rubra vera, oxygen saturation will be normal. No issues about that. Fine. If nothing is there, I'm going to have few disease of hemoglobinopathy. Okay. Tell me few hemoglobinopathies you know. I'm sure you know few hemoglobinopathies. Name a few. Sickle cell anemia, thalassemia, those are hemoglobinopathies. Hemoglobinopathy is a very, very big spectrum. Methemoglobinemia is also in hemoglobinopathy. Amongst that, there are few hemoglobinopathies which can have an higher oxygen affinity. Right? It can have a high oxygen affinity. This is a problem for me. How do you identify hemoglobin with this high oxygen affinity? Again, go back to your physiology. You have your oxygen dissociation curve, right? You draw an oxygen dissociation curve, it will tell you my hemoglobin affinity is normal or not, right? So my hemoglobin affinity is normal or not, there are few hemoglobinopathies with high oxygen affinity. They are rare, it might be asked here. Because if nothing comes, these are the only possibilities. If there is a high oxygen affinity or if the oxygen affinity is normal, right? Again, two possibilities. Hemoglobinopathy is high oxygen affinity. You have hemoglobin Olympia. These are extremely rare in India, right? They are more common in the European countries. That's why the name also comes with Olympia. You have hemoglobin Bethesda. At least you will remember Bethesda because we have read Bethesda in many places. Hemoglobin Santiago. Two reasons. One it is extremely rare, and second reason, we don't evaluate a patient till this time. Polycythemia, we just manage, right? If at all something is required, we manage the patient, keep the patient on follow-up. If you work up everything, you might see cases like this. Maybe an Indian variant also will come up in future, right? This might be a new information for you. These are just hemoglobin with intrinsic high oxygen affinity. These might have mutations responsive to 2,3-DPG, which is going to integrate your biochemistry as well. Still, my hemoglobin levels are normal. What do I think now? Everything is fine. Hemoglobin levels are also normal. Then what you're going to do is, you're going to look for paraneoplastic syndrome. Okay? You're going to look for paraneoplastic syndrome. There can be few paraneoplastic syndromes, tumors which can increase the erythropoietin products level, which can result in polycythemia. Tell me any tumor if you know which causes polycythemia as a paraneoplastic syndrome. I'm sure you know quite a few. One, which is already common in MCQ, cerebellar hemangioma. Hemangioma or hemangiopericytomas. Okay. Sometimes it can be just a simple uterine leiomyoma. Or it could be an hepatoma as well. And RCC. These are few things you already know. Perfect. All of you have told RCC. I kept it last for the only reason we already know it. We are going to read few things. These two we already know it. Hepatoma is hepatocellular carcinoma. Right? These two we already know it, so we'll read it last. These two might have been a little bit new. Cerebellar hemangiomas and uterine leiomyomas. Right? This is going to be a flowchart for an polycythemia rubra vera. Okay. Polycythemia, the management and workup in case of polycythemia. Coming back to this question, it's just a case of hemoconcentration. Whenever you see a hemoglobin high in a real life or in an MCQ, please follow this flowchart. You might not be required to come till this. Most of the cases will be taken care at this level itself, which you already know. If in an MCQ, if you want to create a tough question, this will come as well. Okay? Yeah, VHL is correct question. Fine. We'll go and have a look at the next question. Next question. These are very simple ones. A 6-year-old girl is brought to the emergency room after an automobile accident. Physical examination shows bleeding from multiple wounds, CD Wilson, normocytic normochromic anemia. Which of the following indices is most helpful in defining the anemia of the patient as normocytic? It's a very simple question, which is just asking you, tell me which indices, the RBC indices, is going to help me to know that this is a normocytic anemia. Fine? Fine, that's it. Answer is very simple. Normocytic is directly related to MCV. I didn't put the question for this. I put the question to discuss about MCQs which can come pertaining to the RBC indices, right? There are multiple RBC indices. The common ones are MCV, MCH and MCHC. And we need to know how to diagnose them first, how to calculate them, because there was a question in AIMS which came on the calculation of MCH and MCHC, right? So this is simple. It's a mean corpuscular volume which tells me whether the anemia is normocytic or macrocytic or microcytic, right? So just look at the formulas of MCV, MCH and MCHC. MCV is mean corpuscular volume, which means volume occupied by a single RBC. So what I'm going to do, I'm going to take the entire hematocrit, right, or a Paxil volume for the ease of the words. Paxil volume divided by the RBC number. Paxil volume is the volume occupied entire RBC in a person divided by the RBC number in millions. Okay, divided by the RBC number in millions, which will give me the exact value of an MCV. Fine. Then we have the formula for MCH. These are very easy ones. You must have read this in your physiology practicals. The problem is we would have outgrown this. We grow far away from this. So when a question comes on basic science again, it will become much difficult for us to evaluate it. MCH, the thing is again mean corpuscular hemoglobin. The hemoglobin in one RBC. So it's going to be hemoglobin in gram per deciliter divided by you have your RBC count in millions. Fine. It could be PCV or hematocrit in the first case. Both means one and the same. Okay. Then mean corpuscular hemoglobin concentration. It's the hemoglobin in gram per deciliter divided by hematocrit. It's expressed in percentage, so multiplied by 100. Other two multiplied by 10. Fine. I just messed them. Other two multiplied by 10. The last one MCHC is around multiplied by 100 because it's expressed in the form of percentage. So when you have these things, there are few clues. MCHC is going to be useful in only one disease. I am sure you know that answer. Elevated MCHC. What is the cause? What is the cause of elevated MCHC? We have only one cause for elevated MCHC, which is hereditary spherocytosis. Right? I am going to think of hereditary spherocytosis as the first cause, preliminary cause. Fine. So these are the formulas. So what are questions can stem from MCV, MCH and MCHCs? Either I can give you values of hemoglobin, RBC and ask you tell what type of anemia is it. The next question is based on that. Or I can give an RBC histogram. If you're an intern or a post-intern, you must have seen a patient slip. Right? Go to the lab, give CBC value, they'll give a slip which will have graphs like this, which will have scatter plots like this, all of them, right? And then based on that, you will have hemoglobin and everything. Based on that graph, based on the scatter plot, I can ask questions. That also is based on RBC indices, but not to calculate in the form of a graph. That's what we discussed in yesterday's special class. If you missed it, go to the Unacademy app. Under my name, you can see Man and the Machine Part 1, in which we have discussed about entire thing about CBC analysis. I'll give an MCQ, whatever we discussed yesterday. If you attended the session yesterday, let's see if you're able to solve it as well. Fine. This was the question in the yesterday's class. I'll just zoom it out. This is a bit of an much integrated question. First, only thing what I want you to know, understand first is, look at this image, nothing else, leave the question, look at the image, tell me which value is abnormal. This is how you must have got most of the time, right? One value which is abnormal here in this patient. There are actually quite a few values which are abnormal. One value which is abnormal, striking for me is MCV, perfect. MCV is abnormal here, right? So can I say it is a macrocyte, right? 96 to 100 is normal. I'm perfectly going to call it a macrocyte. The question is, now look at the question. All of the below could be probable finding in a peripheral smear of this patient except, please don't miss except, and just look at the macrocyte and tick this. The question is except, not the macrocyte, right? The question is about except. So I'm having a macrocyte, big RBCs. Tell me which of the following can be macrocytic. A normal macrocytic RBC can be bigger. Most important finding here is the second thing. Macrocyte could be an RBC, which is bigger, or it could be an reticulocyte. Remember this for sure. Reticulocytes are bigger than a normal RBC. So if a blood has lots of reticulocyte, it will be a confounding factor pushing them to elevate the MCV levels, right? So these two are the possibilities. Now answer again the next step of the question. Which diseases will have high reticulocytes or reticulocytosis? If I see a patient with reticulocytosis, what will be my first diagnosis? My first diagnosis is definitely going to be your hemolysis, right? Perfect. Hemolysis will be the first thought for me. So when I have hemolysis, reticulocytes count will elevate. This indirectly is going to increase my MCV, right? So can I see spherocyte in a hemolytic anemia? Yes. Can I see agglutination in hemolytic anemia? For sure, right? Agglutination is nothing but it's seen in cold autoimmune hemolytic anemia. Spherocytes can be seen in many hemolytic anemia, right? Can be seen in many hemolytic anemia. Perfect. So this is what I'm going to, we can solve from this hemogram. This will be given in your patient profile, it will be there. So the answer here is going to be pencil cells. Okay, I'm going to take the same MCQ to the next level. Same MCQ, no change. I'm going to just make only one change. I hope you got this. It's an indirect question targeting on macrocyte. I'll just erase all these things. I'm just going to make a tiny little bit of change. Let me see how many of you can catch it. I'll just remove except. Okay. What is the most common finding here seen in the peripheral smear? Most appropriate finding for this patient. I have removed except. You have to pick one. So when I have to pick one, I'll zoom out on the histogram again. When I have to pick one here, look, there are two values which are problematic for me. One is MCV. Other one is again little bit on MCHC. Ideally, this should have been MCHC. Consider this as MCHC. Fine. Okay. MCHC, let's assume it's in 39.6. I'm just tweaking the question a little bit. When MCV is high, saying this is a hemogram of patient of hereditary spherocytosis, tell me what could be the clinical scenario of the patient. We are just going to amplify it a little bit more and more. The patient is, now we are diagnosing it on as preliminary diagnosis of hereditary spherocytosis. Why is MCV elevated in hereditary spherocytosis? Because of reticulocytosis, right? It's been elevated because of reticulocytosis. So if I'm having a patient being elevated because of reticulocytosis, the patient is going to have lots of hemolysis, correct? Okay, the patient is going to have lots of hemolysis. So this patient is hereditary spherocytosis with hemolysis, with an active hemolysis, in other words, right? With an active hemolysis. Again, we are going to go to the next step. We'll read everything regarding a topic with one finding. So I'm having something with an active hemolysis. Hereditary spherocytosis is an active hemolysis. Tell me, it will be stuck for a second, it will come back. Tell me, hereditary spherocytosis is a low-grade anemia or a very severe anemia? HS is a low-grade anemia or a very severe anemia? It's definitely a low-grade anemia, right? It's definitely a low-grade anemia. And I'm going to have a low-grade anemia. When will you have active hemolysis in a low-grade anemia? Perfect. We have crisis. Super. So this patient would have been, if this is my MCHC, if this is my MCV, this patient would have been in crisis. Crisis in some case of hemolytic anemia. This is, in one crisis there will be more hemolysis. In the other crisis, the hemolysis will be very less. Perfect. This has to be in hemolytic crisis, right? This has to be in hemolytic crisis. For the only reason, my hemolysis is more, my reticulocyte response is more, that's why my MCV is elevated, right? That's why my MCV is elevated. So with this information, which looks very subtle, an experienced pathologist can give you lots of information inputs for it. So if I'm going to see this finding, I will give all these as my differential diagnosis, right? I'll give all these as my differential diagnosis. Okay, there are a few connection mistakes. I don't know what. It'll come back again. Fine. Okay. So all these information can be bought just by a simple hemogram. That's why, see, what's going to make you the best doctor is not the amount of knowledge you have. The amount of knowledge plus the application. Application is going to make you the best doctor. I hope the future next on NEET. I hope it's fine. The speed looks good, Pratik. I don't know what's the problem. I am not so much of a techie. I'll get the help of the tech people in the team and hopefully it will not happen in the future sessions. Fine. Hope it's a bit better now. It's a bit blurred. The next question is a 25-year-old person. Is the screen clear? For me, it looks a bit blurred. Yeah, Sumit, I'll do that as well. Okay. Decrease appetite, and these are the informations given to it. Ashutosh, I didn't do anything. I just went to the next question. Fine, that's all. Okay, these are the two informations given for us, and based on that, we have to find what's the diagnosis. We're going to apply the formula of MCV here. MCV is your PCV. Sure, Pavan, I'll see. My speed looks good. Let's see. PCV divided by RBC in millions, right? So we're just going to apply. This was a question which came in AIMS exam. PCV is 30 into 10, right? We should not miss that. MCV, RBC in millions is 2 into 10. My PCV here is 150. This bit of a mauve thing, MCV value is very, very high here. So very safely I can say it's a macrocytic anemia. Definitely not sideroblastic. Sideroblastic comes in the differential of microcytic anemia. Alpha thal, no. It's like beta thal, microcytic to normocytic, and deficiency microcytic. The only option left here is folic acid deficiency anemia, right? It's a macrocytic anemia. So my only answer will be folic acid deficiency anemia. This came in an AIMS exam, and many students didn't know this only for the reason they would have forgotten this, right? Few questions in every exam will go back and test your basic science knowledge, very, very basic science knowledge, and few of them will be very high-fi. You should not miss the basic science questions. High-fi questions because no one knows. This you have read. Please try to recollect it back, and hopefully you will get the answer correct, right? It's a question based on your values. We'll go to the next question. I'm sure you'll answer this question very easily. Okay. A 24-year-old man presents with signs and symptoms of mild anemia. Physical examination finds mildly enlarged spleen. Lab investigation, normal liver serum enzyme levels, and negative direct antiglobin test. So Coombs test is negative. That's one important negative information required for us. His blood cells show an abnormal osmotic fragility as seen in the picture. The dashed area represents normal cells, right? This is normal. Okay, the shaded area, and the dashed curve is the result. This is the dashed curve, which is the result. So what could be the pathogenesis in this person? You know the diagnosis here. The diagnosis here is straightforward. My diagnosis here is definitely going to be an hereditary spherocytosis or a spherocytic anemia. Based on the options given, I'm going to presume safely it is hereditary spherocytosis, right? So it's hereditary spherocytosis. My answer here is ANCA. ANCA is a common mutation. If there's any other mutation also, kindly disregard that. Okay, ANCA is a common mutation seen in hereditary spherocytosis. Fine. I want to discuss few screening tests here. One is your hereditary spherocytosis for sure. Osmotic fragility is for spherocytosis for sure. There are few other hemoglobinopathies. You are going to tell me what are the screening tests for those particular hemoglobinopathies. Let's assume few hemoglobinopathies. A few screening tests for hemoglobinopathies. First is your hereditary spherocytosis. Okay. Second is your, let's say, sickle cell anemia. Third is your G6PD test. For all of them, tell me what is the screening test. See, diagnostic test is different. Tell me the screening test, and if possible, we'll discuss few things about the screening test as well, if time and network permits. For hereditary spherocytosis, the screening test is very simple. Is your osmotic fragility test. The better one ideally will be if the option of these both are given. It's an incubated osmotic fragility test. Incubated osmotic fragility test is much better than a routine osmotic fragility test. Fine. Incubated osmotic fragility test is nothing more. I'm going to get a sample. I'm going to wait for some time. After 24 hours, I'm going to do the same osmotic fragility test, nothing else, right? It's an incubated osmotic fragility test. Sickle cell anemia, the test is sickling test. Okay. In G6PD deficiency, we have a test called methemoglobin detection test. Test called as a methemoglobin detection test. Fine. There are 3 screening tests in case of hereditary spherocytosis. Fine. Spherocytosis, sickle cell anemia, and G6PD. I wanted to discuss these 2 tests as well because generally we miss these 2 tests. We don't know the procedures of these 2 tests. OFT we already know. I'll discuss OFT now. These 2 tests, I'm going to have 2 more revision sessions on RBC and WBCs in the Unacademy app in the form of special classes. Catch in there. I'll put a schedule in the Telegram app group as well as in my Instagram. There'll be 2 things, one in the morning and one in the evening. Whenever you're free, you can attend both. Fine. So we'll be discussing these 2 tests, the principles, how to interpret them tomorrow, and today we'll be seeing a little bit about osmotic fragility test, which you guys already know. OFT, first question which comes in OFT is the anticoagulant. That's extremely important for OFT. What's the anticoagulant used for OFT? The anticoagulant used for osmotic fragility test is perfect use heparin. Heparin is the anticoagulant used for osmotic fragility test. The reason why we use heparin is where there will be very minimal alteration in the volume of RBCs, volume or shape of RBCs. If you use EDTA, even a tiny EDTA presence will slightly alter the morphology of RBCs, not so much, slightly alters the morphology.